Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from B1.
Good afternoon. It's good to see you both. I know this has been a challenging time for you and your family. How are you feeling today?
We're still trying to wrap our heads around all this. We really didn't expect to hear I had stomach cancer. But I'm also anxious to find out what's next. What are my options?
Absolutely. And it's important to have these discussions. One of the key steps in your treatment plan will be biomarker testing. This will help us understand the specific characteristics of your cancer and guide us in choosing the most effective treatment options.
What does that mean for her prognosis? Can she be cured?
Those are important questions. Prognosis can be difficult to estimate and is even more complex now that personalized treatment options are available. We'll check for several different biomarkers. These can tell us how your tumor behaves and how it's interacting with your immune system. Then we can select the best treatments that will work.
So, does that mean we have to wait for the test results to know what my prognosis is?
Yes, we've already sent it off, but we'll need to wait a couple more days for the biomarker report. Once we have that information, we can discuss everything in more detail.
We understand. It's just overwhelming to think about all of this. Our children are so young and we all need her.
Absolutely. This is a lot to take in. Please know that we are here to support you. Our goal is to provide you with the best possible care tailored to your specific situation. Once we have the biomarker results, we can create a comprehensive treatment plan together.
Thank you for explaining everything. We really appreciate it.
Of course, we're here for you both. I will also send you home with more information on the biomarker testing we ordered to help explain how we'll use those results. Let's just take this one step at a time.
Hello, I'm Sylvie Lorenzen, Associate Professor at TUM University Hospital, rechts der Isar in the Department of Medicine 3 in Munich, Germany. The scene you just watched illustrates the type of conversation that can occur between a patient, their caregiver, and their physician when starting to decide which treatment options to use for gastric cancer. According to national and international guidelines, biomarker testing in metastatic disease is key. And the ESMO guidelines recommend 5 to 8 samples to have adequate tissue available. For PD-L1 testing in particular, use of immunohistochemistry is necessary. And the two scoring system recommended are CPS and TAP. To prioritize, MSI is most important, followed by HER2, PD-L1, and Claudin 18.2. And we know nowadays that about 80% of our patients have at least one biomarker present, which can be targeted by effective and approved agents. Prognosis strongly depends on the results of the tests and can be from potential cure, even in the metastatic setting, for example, if there's MSI high or a high PD-L1 score, to a poor prognosis in case of totally absent biomarkers. Therefore, adequate and honest communication techniques are of utmost importance. Effective but also honest techniques as used in the case are important, and even to explain in case there are no sufficient biomarkers available at the time that new biomarkers are under evaluation and may become available soon, and that the mere fact of gaining time with the currently available therapy can give hope that new effective therapies will be available in the future. It is also always important to point out that the result of the biomarker test must be awaited in order to be able to recommend the best possible and individual therapy for this specific situation. It is also important not to rush into anything now, but to wait for the result. The doctor also involves the husband and emphasizes that he supports both of them. The partners are a team sitting in the same boat. The doctor encourages the husband to ask important questions, the answers to which are necessary to decide on the right therapy. And this gives the husband as well as the patient concerned confidence in dealing with this new life situation. So, for our current case, Eliza's biomarker report has come back and shows that her tumor is positive for PD-L1. She and her husband have returned to the clinic. So let's listen in as their doctor discusses the biomarker results and what they mean.
Good morning. So good to see you both again. I have the results from your biomarker testing, and I'd like to go over them with you.
Thank you. I'm eager to hear what they say.
So, your results show that with a score of 10, your tumor is positive for the biomarker PD-L1, or programmed death ligand 1. It's a biomarker related to the immune system, and the expression in your tumor is high. Your tumor is negative for other biomarkers we looked at, including HER2 and Claudin 18.2.
Okay, so what does all that mean for her prognosis?
Having a high PD-L1 expression level is a good sign because it indicates that your tumor will likely respond well to the therapies that target this pathway. There are several immunotherapies currently available for advanced gastric cancers that express this biomarker. These are given in combination with chemotherapy and can greatly improve your prognosis.
That's good to hear. I'm glad there are options available. So, being negative for those other biomarkers is okay?
Yes, each of the biomarkers I mentioned help us determine which therapies might work best. In your case, the tumor expresses only one biomarker, and that will inform our decisions. Now, I'd like to understand your goals regarding treatment. What are your thoughts on how aggressive you want to be with your therapy?
I want to do whatever it takes to fight this cancer, especially for my kids. I am worried about side effects. I want to be able to go to my kids' activities and continue running my business as much as I can.
That's completely understandable. It's important for us to align your treatment plan with your personal goals and preferences. Now, let's talk about your treatment options.
So, in this conversation now, the physician comes immediately to the important biomarker point and first explains the good news. PD-L1 is positive, and that means there are good treatment options for IO plus chemotherapy, and this directly impacts the prognosis. So, one method to gauge patients' understanding of the conversation is to have patients repeat back what they heard. And another method is to have a caregiver present to help retain this information. This is also very important that helps the patient as well as the husband and the relatives to better understand what the physician said, because they might be nervous, they might be distracted, and they might be overloaded from a bunch of information. Also, maybe not spoken in their normal language, but more in academic language. And another thing is to provide written summaries of the important information discussed so that the patient and the family and relatives can repeat it at home and maybe underline and ask further questions. And I also always think is what is a good method is to maybe also draw a picture on the mechanism of action. So to explain how PD-L1 antibody works. So for me, these are the most important methods for conversation. And the approach of the physician is really straightforward. Maybe for me, it's a bit too academic, but I just mentioned to speak in a more patient related language, just given the biomarkers and categorizing into positive and negative. And this seems that the husband is quite confused at the first glance. So, however, a physician is intuitive, gives perspective without being unrealistic, and of course, most important, that time matters. So for me, this was a really interesting conversation. And I also like a lot how the physician asks for the patient goals. For example, now I'd like to understand your goals regarding treatment. What are your thoughts on how aggressive you want to be with your therapy? And this is important because patients want to take an active part and retain freedom of choice. So now that they have discussed her treatment goals, let's rejoin Eliza as she and her husband discuss treatment options with her doctor.
Let's talk about the treatment options available to you. Given that the tumor is PD-L1 positive, one effective approach is to use PD-1 inhibitors in combination with chemotherapy.
What does that type of treatment involve? How does it work?
The PD-1 inhibitors work by enhancing your immune system ability to recognize and attack cancer cells. When we combine it with chemotherapy, this treatment can be even more effective in controlling the cancer. These therapies are given intravenously, so you'll need to come into the clinic for each treatment.
Okay. What about side effects?
These treatment options differ somewhat with regards to how often they are given and what side effects are most common. We'll talk through each one to make sure we are selecting the best option for you. We want to focus on treatment, but I also want you to prioritize spending time with your children and family.
And that's a good point. How can we make sure Eliza has the support she needs during this process?
I recommend that you both connect with our oncology nurse navigator. They can provide resources, answer questions, and help coordinate care. They can also assist with any logistical concerns you might have.
I appreciate that. I am definitely a planner, so I want to make sure I'm as prepared as possible.
Absolutely. It's important to have a support system in place. There are several patient advocacy groups that can provide resources and support. Our team will help find the right one for you and your family. We can also connect you with a social worker and counselors to provide emotional support to help you both navigate this journey. In addition, we have some excellent printed materials on the treatment options we've discussed today for you to take home. They discuss how these therapies are given, what side effects to watch out for, and when to contact us if you have any issues.
Thank you for that. I'm sure I'll have more questions after we've had some time to think. And it's reassuring to know there are people who can help us through this.
Of course, we are here to support you both. My team will make sure you have all the information you need to make informed decisions along the way.
There are 3 landmark trials on first-line chemotherapy in combination with checkpoint inhibition in HER2-negative disease. The first one was the Checkmate 649 trial, looking at the combination of chemotherapy plus nivolumab, and nowadays this combination is approved for all patients with a CPS of 5 and higher in the ESMO guidelines due to the improvement in overall survival and progression-free survival. AEs included nausea, diarrhea, and peripheral neuropathy, which were all basically increased by the chemotherapy, which was oxaliplatin based and 5FU based. The second trial was the Keynote 859 trial, another global phase 3 trial looking at the addition of pembrolizumab to chemotherapy. And it shows a significant improvement in median overall survival as well as progression-free survival for all patients with a CPS of 1 and higher. And the AEs were pretty much the same as has been shown in Checkmate 649 trial with nivolumab. And last but not least, the last trial, a global phase 3 trial in this indication, was the Rational 305 trial, which led to the approval of tislelizumab in combination with chemotherapy for all patients. This trial showed a significant improvement in median overall survival and progression-free survival with the addition of the checkpoint inhibitor. And in this trial, the TAP score was used, which is a bit different to the CPS because it goes on the area, but it's quite comparable when we look at the different cutoff points. So TAP of 5 and higher. So based on ESMO guidelines and EMA approvals, CPS of 5 and higher, as well as TAP of 5%, is the common threshold at which all 3 immunotherapies can be used with chemotherapy in first-line HER2-negative gastric adenocarcinoma. Looking at the NCCN guidelines, they recommend using immunotherapy in combination with chemotherapy for patients with a PDL1 of 1 and higher. So, in order to decide what is the best available treatment, as shown in the video, shared decision making is a joint progress in which a healthcare professional works together with the patient to reach a decision about care. And I think in the video, this has been shown very professionally. So, for me, I think most important for the patient is that the patient is involved in the decision because patients want to be actively. They don't want to be passive. They want to be involved in decisions with the healthcare professional, and the decisions should be made together. Patient decisions aid support the conversation and help patient make informed choices. And there are several tools now available to support shared decision making for such specific conditions. I also want to highlight the role of specialist nurses and multidisciplinary teams in supporting patient outcomes and fostering open communication. And also, patient advocacy groups shouldn't be forgotten because they are really important for the patient communications. And I think as we learned now in this wonderful communication, to discuss from the beginning what is important, the biomarkers, the decision taking together, and finally, to talk about the prognosis, which is very individual nowadays, and also to address the point what is coming up in the next future and that time really matters, that it is the prolongation of lifetime, not only to be cured, but to gain more lifetime also in order to give time for new developments which are on the horizon because there is so much light at the end of this tunnel in gastric cancer. There are so many new biomarkers coming up, which might, for specific patients, even prolong life longer. But there is still a lot to be learned. And with this, I want to conclude this session, and I thank you very much for participating in this activity.